I like to say my name is Prash and I'm a psychedelic psychiatrist. But then that's a lie, seeing as we're still very far from psychedelic research in this country. So I'd like to be a psychedelic psychiatrist. I work as a doctor at a major metropolitan hospital in Melbourne. And having these kind of conversations in that environment is extremely difficult. So it is very comforting to be here where the world is my mushroom, really. And I'll pass it on.
So, my name's Stephen Bright. I'm a clinically trained psychologist. I've worked with people with alcohol and other drug use dependence for the past 15, 20 years, and also worked in mental health, and have become increasingly interested in the role that psychedelics could play in enhancing current psychotherapy, given the inefficacy for a range of disorders, not only substance use, but PTSD, treatment refractory depression, and all kinds of areas where psychedelics may have utility. And have recently moved to Western Australia to Edith Cowan University to head up their drug and alcohol studies program.
Hey everyone, my name is John Harper. I'm a medical student at the University of Queensland up in Brisbane. I previously worked as the study coordinator for the MAP-sponsored MDMA study just north of San Francisco in Marin County. More recently, I was working at a clinic up in Brisbane that uses ketamine for depression treatment and PTSD treatment. I guess my main interest at this time is, and something that I've been talking about a lot with people, is the exciting things surrounding incorporating psychedelic medicine within sort of Western allopathic medicine, but also some of the potential downfalls and some of the concerns that I have bringing those two quite different worlds together. Yeah.
Hi, I'm Nigel Strauss. I'm a psychiatrist in private practice in Melbourne. Have always had a great interest in post-traumatic stress disorder and its management, and frustrated at the lack of progress that we're making with treatment. A lot of people are left still with the condition, and psychiatry is not really up to the job at this stage. So I've become interested in psychedelic research the last 5 years or so, and Martin Williams and I attempted to initiate some research a few years ago, but we were not allowed to do it. We couldn't even submit our protocol to the ethics committee at a university I'm associated with. And so I find myself really developing strategies, trying to educate people, publish a few papers, and just drive the process further in my own small way. And I'm heartened by the fact that more and more people, not only at these conferences, but in the straight world, if I can put it that way, are becoming interested and supportive, and I'm becoming increasingly optimistic that we will get research happening in this country in the next couple of years.
Hello, good morning. My name is Ben Sesor. I am a consultant child and adolescent psychiatrist from Bristol in the UK. For the last 10, 15 years, I've been working in the field of psychedelic research. Together with colleagues at Imperial College London, my supervisor is Professor David Nutt, and working with him and Robin Carhart-Harris and others in Imperial, in the last 10 years we have carried out psychedelic research with Psilocybin, LSD, DMT, ketamine and MDMA, and I am currently running the UK's first clinical MDMA study using MDMA-assisted psychotherapy to treat alcohol use disorder. So I work in addiction psychiatry 1 day a week with adults. Another day a week I work with children in a secure custodial setting, 11 to 17-year-olds on long prison sentences. 3 days a week with the MDMA psychotherapy study, and then private practice and court work. And although all of those 5 different jobs seem a little bit crazy and disconnected, for me they all make sense because they're all tied together with this developmental trajectory from early childhood trauma and abuse into adolescent mental disorder and adult addictions. And at the end of that line comes MDMA psychotherapy. So it sounds a bit mad, but it makes sense in my head. And the other thing I do is I'm the founder and president of another psychedelic conference called Breaking Convention, which is a UK-based thing. So it's really lovely to be here and not have to be involved in running anything and just being able to lie around and enjoy the place at the world's second best psychedelic conference in the world.
Hello, good morning. My name is Rita Kochava. I'm interested in psychedelic therapy for many years, but I get more involved when I, around 6 years ago, got to the Takivasi Center, which is the center in Peru where they are treating addictions by combination of traditional Amazonian medicine, including ayahuasca and psychotherapy. And after that, I got the job in National Institute of Mental Health in Prague, in Czech Republic, where I'm working as a researcher and also sitter in the psilocybin clinical trial. We are giving psilocybin to the healthy volunteers there. I'm also trainee of the MDMA for PTSD therapy training organized by MAPS and of Gestalt therapy. And one of my main big areas of research is also studying the psychedelic therapy, how it was conducted in 60s, because the research and practice in those times were huge, were rich, and to get the same amount of knowledge and experience which we get during those times will take dozens of years for us currently. So I believe we can learn a lot from that.
Good. Now you know who we are. I thought I should say that none of us are actually waving at you. It's just the fly situation in this square meterage is pretty relentless and apparently quite different from what it is across the other side. I just thought I should make that clear. Apparently now I have the opportunity to pose whatever questions I want to this lot, and I'm going to separate myself from this, and that is the panel, and I'm technically facilitating and don't have to answer any of this. But the first question I had for everyone, and I wonder if we could go through this one by one, is, as a psychedelic therapist, what would be, I guess poison of choice is the wrong word, but therapeutically, what is the substance that most speaks to you, that you would like to see yourself using and as a therapist, and why? Anyone who wants to start?
I'll start. I don't think I could put it down to one particular substance, because I think different substances have different potential for different disorders. So obviously MDMA for PTSD, but I think psilocybin holds a lot of potential in terms of depression, end-of-life anxiety, and many other areas, possibly even for healthy volunteers, for improving wellness, increasing meaning and purpose in life, etc., etc. So I don't think I can narrow it down to one.
Yeah, I'm not a therapist, not yet, but I think that one of the issues, if we look at what's been happening with clinical trials, and you see that MDMA, ketamine, and psilocybin have all been shown in various clinical trials to be effective for what's termed in Western allopathic medicine as depression and PTSD and end-of-life anxiety. But people who are intimately involved with all of those substances, especially in underground work where they have the opportunity perhaps to work with all of them in a less regulated sense, those disorders or those diagnoses aren't really encompassing of the nuances and the subtleties of a person's psychiatric issues and so or personalities. So I think that I think that each of those substances will play a role, and I think that through better diagnostics and better characterization of things like depression, that I was having this discussion last night with somebody that I think, in the future with better imaging and a better understanding, we'll probably find out that depression is, that might be 15 different things for different people. And I think we have a poor, too broad of a brushstroke when we're diagnosing people. And I think that the values of each of those psychedelic compounds will play a role in different roles in different times in people's lives and for different people.
Psilocybin. I think it's a true psychedelic. I think that the transformative or mystical experience, whatever you want to call it, is the key. And I think that, following on from what was just said, that depression, this word depression, it means everything and it means nothing, because the World Health Organization talks about depression now being the most common illness in the world, and it causes more disability in the world than any other condition, which is pretty outstanding, outrageous too. What do we mean by depression? I think you're quite right that there's so many causes. My thing is that, and I'll be talking about it a bit this afternoon, that what we're seeing is a sort of thing called, I'll call it a cultural deficit disorder, in that our culture isn't providing people with the narrative that gets you through life, provides you with meaning, purpose, understanding things, virtue, all that stuff. And what people are seeking and what people are missing out on is this sense of meaning, this sense of purpose. And I think here's a drug or a range of drugs that might be able to help us in that way. But psychiatry, unfortunately, isn't orientated towards that introduction, and I think we need to work hard, well, I'm trying to anyway, to try and reorientate psychiatry and psychiatrists so that we can accommodate that process of a meaning-orientated drug. And I think that psilocybin, because of it's not going to hit people as hard as LSD, and because we can manage it more effectively, and there's some terrific work already being done. And I'm speaking to someone who hasn't actually researched psilocybin, but I'm very interested in doing that. But this drug might be able to help a group. I'm not saying it's going to cure everyone with depression, but there's a group of people, and potentially a large group of people living in 2017 in Western culture, who are struggling to work things out. And the experience of psilocybin, I think, is going to be something that may very well help them. I'm a researcher, and I'm not coming down saying it's going to. I think we have to be sceptical. But I think there's an enormous amount of potential. I wrote a paper that was published in the Australian Medical Journal earlier in the year about the use of psilocybin for end-of-life anxiety and depression, pointing out that many people who want euthanasia are people, I understand they're in terrible circumstances, but I think there's a group of them who are struggling to come to terms with death. They just can't face the thought of death, and they want a shortcut out. And I think that there's a real need here too to explore potentially the use of psychedelics in this area, so that, I'm not saying we're going to save people's lives, but maybe they won't choose the path of euthanasia, but they'll go through a process, hopefully with psilocybin, where they can come to terms with death. I mean, death and life, as you all know, you can't live well if you don't understand death, and vice versa. And so I think there's enormous potential here in that area as well, for people to discover meaning and to come to terms with their situation. So that's my great interest, and hopefully one day we'll be able to pursue it in this country.
Mental illness and mental well-being has nothing to do with pharmacy or drugs, and no amount of drugs, whether the prescribed licensed drugs we have or psychedelics or any other chemicals, are going to provide people with mental well-being and health. Mental well-being and health is a holistic state of mind and body that comes from a sense of hope and positivity, removing exclusion, racism, barriers, poverty, poor housing, providing education, good treatment for single mothers bringing up children. Medicine, and particularly psychiatry, is a holistic study of mental well-being, and this includes social and spiritual well-being. So if you're going to be a good psychiatrist or doctor of any kind, you don't concentrate too much on drugs. But And indeed, everybody I know who's interested in psychedelics are essentially psychotherapists at heart. And whilst perhaps the general public would focus on the drug aspect of the work we do, it's not about drugs. It's about using this tool in a very short, transient way to provide an effective and safe form of psychotherapy, which allows a person to connect with themselves and their environment. So having looked at quite a wide range of different potential pharmacological options for enhancing psychotherapy, I'd agree with the rest of the panel that there's different drugs that are useful in different cases and with different people. And different diagnoses. Although I'm not a person who's keen on diagnosis, I think that patients often want diagnoses, they want a label, and so I'm happy to give them a label. But generally the only diagnosis is John Brown or whoever the patient is sitting before you. That's their diagnosis, and they have a very individual presentation. So we don't want to restrict ourselves to labels nor drugs. MDMA, though, I think is a very useful tool because it's very safe, and it's a non-specific enhancer of psychotherapy. It's also a very tolerable drug, which is quite important, and a lot of patients cannot tolerate the idea of a classical psychedelic like LSD or psilocybin, or even tolerate the idea of such drugs. But MDMA has some really unique pharmacological and subjective psychological properties that make it very tolerable. It's invariably pleasurable. There are a few drugs in psychopharmacology that are invariably pleasurable, the opiates being the others, which makes it a useful clinical tool. It's relatively short-acting, and it has a very wide range of psychological properties. So at the moment, I'm very much pinning my colours to the mast of MDMA. But also, with the work we're doing with alcohol, I think we're going to be broadening out the use of MDMA. Of course, it has this very strong grounding in post-traumatic stress disorder, but I also think of trauma with a small t, so not necessarily the whole diagnostic category of PTSD, but that trauma with a small t underpins most, if not all, long-standing mental health problems for the patients I see. So I can see MDMA being broadened beyond PTSD into addictions and other mental health problems. So let's see where this goes, because we're just in the very embryological part of our understanding of using these substances within medicine. And 10 years from now, it's going to be even more exciting.
Yeah, so in my ideal world, I would have the range of different tools, different psychedelics, because yes, it was mentioned before that like each psychedelic has a bit different specific properties, and also patients and people are very different, and in any person and with different disorders, but also in different stage of treatment can be more useful another substance. So I wish not to be limited to just use MDMA or psilocybin, but to be able to choose together with the patient, with the client, what could be the best choice at this moment. Because yeah, for example, MDMA is great if you want to work on the past trauma, but sometimes you also don't want just to have a tool to facilitate psychotherapy, but because you can be stuck on that with the patient as well. But sometimes you want really just to provide the psychedelic peak experience, where there is no possibility really to talk about the childhood issues or traumas or anything else, where it is more about the pure mystical experience, which can work as kind of restart in your life. And there psychotherapy serves more as a support to the psychedelic therapy, not the other way around. yeah, so for me, if I would have to choose, yeah, I like psilocybin. I believe that's a great tool. Also MDMA, and I also see the great clinical benefits in secretion from Bufo alvarius toad, which is very very fast acting and super intense experience from that group of the intense peak mystical experiences. Mm-hmm.
Thank you, everyone. I'm just going to go with something that Ben spoke about. You were talking about the holistic approach that's necessary, and that we shouldn't be reducing ourselves to just the pharmacology of it. And I guess in psychiatry, we think of the biopsychosocial model of treatment, of diagnoses, where you target various different aspects of a person's life that is contributing towards a particular condition. I'm going to use that as a segue to talk about when we're talking about psychedelic therapy. And I know the answer to this question is probably, does it matter? But I'm going to be purposefully obtuse about it and ask the question anyway, for the purpose of discussion. How much of the effect, if you can attempt to quantify it or qualify it, how much of it do you think is down to the true pharmacological effect of the substance? How much of it is the psychological insights that come from the experience? How much of it is a therapeutic relationship with the therapist? Are there any other factors that I haven't mentioned which you think are far more important in causing this sort of therapeutic effect? Is anyone with an opinion?
Well, this is especially relevant, I think, right now with ketamine research. There's been an attempt in the last few years to try to elucidate an active metabolite of ketamine that's non-dissociative and pin its antidepressant effects on that. And there was a paper last year that came out that said that they found it, at least in a mouse study, and it's something called 2R6R hydroxynorketamine, and they say that that's a metabolite of ketamine that doesn't have what they called side effects, but what I would call positive psychedelic effects. But I think that that's not probably an entirely accurate picture, and I think that even if an active metabolite of a substance does have some efficacy in terms of a biological underpinning to antidepressant effects, that at the very least that psychoactive effect in the person, or psychedelic effect, can have a reinforcing effect, can be able to tie some kind of memory back to their experience. But I think that's in the least, and I think in reality it probably is the case that the psychedelic effects do have a critical role in not only the antidepressant effect, but in reassessing a traumatic experience, or in reassessing someone's own personality, or somebody's own social situation, and I think it's sort of detrimental to try to, well, maybe not detrimental, but I don't think it's the right path to simply try to underpin all this stuff with a biological model. At least, perhaps everything has a biological underpinning, but I think there's better models and better frameworks to understand the transformative experience in a person.
Can I just say, as a psychotherapist that hasn't had the opportunity to work with psychedelics to enhance psychotherapy, that the therapeutic alliance is fundamental to clinical outcomes. And so regardless of what particular therapeutic approach a psychotherapist has been taking, meta-analysis has shown that the therapeutic alliance and the accurate empathy that's shown by the therapist has more predictive outcome of for clinical improvement than any other variable. Therefore, the therapeutic alliance has to be the foundation on which any of this other sort of talk that we're having is based upon.
Anyone else?
I mean, there's one way of answering this question is just looking at the way in which we carry out human pharmacology research, in which we make a very quantitative effort to separate out the active pharmacological component of the drug versus the other non-pharmacological aspects, using a double-blind placebo-controlled study in which we hope to remove all bias and get this clear picture. So you can give a very clear quantitative answer to your question for different drugs if you look at research in that way. And if we look at psychedelics, or if we say look at other drugs, say analgesics, painkillers, most of the painkillers we use have a 65% placebo effect. So that's a very high placebo effect. SSRIs are around about 40 to 45% placebo effect. If you look at Michael Mithofer's study with MDMA for PTSD, the pilot study, it absolutely blows out of the water the current best treatments for PTSD with a randomized control study. So the placebo effect is not a negative thing. The placebo effect is something to be used and to be valued. If you went along to your doctor to have antibiotics and she said to you, these are a bit rubbish, they probably won't work very well, then you're probably not going to do very well with that infection, with those antibiotics. So we use the placebo effect all the time. We have to instill hope and positivity with the treatments and with the patient before us. And that's not fake or trickery, that's just being a good clinician, is instilling a sense of positivity and hope. I think the other way of looking at this question is it's not just the drug, because the drug is the platform and the springboard for other changes. Taking the drug, the psychedelic, alone is really going to have minimal effect. It's when it's combined with those other factors, and they are active factors. They're not confounding factors. The placebo effect in the context of psychedelic therapy is an active therapeutic part of the drug, and you can't screen it out, and you ought not screen it out. We have to instill positive set, and we have to use these drugs in a positive setting. And they're not confounders, they are an active part of how the drug works. But then, even at the end of the therapeutic course, the next question is, and now what? And this is where it's essential that a person who's been through these experiences then looks at broader aspects of their life, their lifestyle, their diet, their exercise, their pursuits, their interests, their relationship to consumerism and the planet, and then moves forward into a new lifestyle. And I think this is really important because, again, this isn't just icing on the cake, confounding factors. These are an active part of why the therapy works, because they push you into a new way of living your life that's more healthy. So the pure sort of hard-nosed scientists would want to remove all of those biases just to get a chemical effect of the drug and then tell us whether it's worth it or not. But I don't think we can or need to remove those biases. They are an active part of why it works.
I agree with everything Ben just said, and I think one of the problems with psychiatry today is that it has a sort of pathogenic approach to illness. We look for all the things that make us sick. We don't look for all the things that make us well, such as laughter and good diet, good exercise, relationships, our relationship with nature, the ability to look into oneself, to self-explore. And this is why I think we need, when we're trying to introduce the psychedelic paradigm into the psychiatric paradigm, we need to look at psychiatry in a different way and encourage these positives rather than focus on the negatives. And that's a very important part, I think, of any psychedelic-assisted psychotherapy.
Yeah, in line with what Ben was saying. In Takivasi, also, like Jacques Mabi, the founder of the center, was when he was talking about the importance of ritual and having the intention that is actually not just with ayahuasca or with psychedelics. So we talk about set and setting in terms of psychedelics, but set and setting is important in any kind of treatment. We have studies that show that if the doctor who has a white coat gives you a pill, it is more effective than when he doesn't have a white coat. And also the color and size of the pills plays a role. So yeah, and I remember that Stan Grof also said that he's persuaded about that one of the most risky and harmful approaches to psychedelic therapy is to see it and use it as a pharmacotherapy, because in some sense it is also different from other pills, because the other pills we use for the specific symptom, we expect the fast effect on this specific symptom, but with psychedelics it is not like that. Psychedelics work more as a universal tool. It can work on different levels, on different symptoms, and depends on how, most of that on how we use it. And also how we approach it as a patient, we can and we can call it the placebo effect, but in psychotherapy we call it positive expectations, which is one of the most effective therapeutic factors of psychotherapy.
Nigel talked about the things that are wrong with our profession in psychiatry. There are a lot of things that are wrong with our profession, but I think one of them is the sort of pompous standing with which we hold onto our training as psychiatrists, or perhaps even as psychologists, and leads me on to a question about that training and how its translatability to psychedelic therapy, because psychiatric training or clinical psychology training doesn't necessarily train you to be a psychedelic therapist. And yet we've seen the rise of a lot of underground therapists who are perhaps more psychedelically linked or psychedelically trained than they are psychiatrically trained. I'd like to pose this question to anyone about where you see the role of underground therapists. This could be a controversial point, whether you see it as being more useful than it is harmful, potentially more harmful than it is useful. It is a relatively contentious point.
Well, I think that underground therapy obviously has a place and a role, and I think it's probably been an initiator of these sorts of conferences that we need to, unfortunately, officialise what's been going on, because I think it will remain underground and we need to get it above ground. And I think, and Ben talks about this a lot, I know, we really do have to go down the route of objectivity and scientific concerns and look at it that way. So that these things can become mainstream. There's no point, I think, in maintaining it as an underground pursuit, because it means that a lot of people, for a number of reasons, will miss out on the potential benefits. And I think that we have to continue doing these sorts of, having these sorts of meetings to discuss it and to bring it out into the open, and then to do the sort of research that's being carried out successfully in other parts of the world. So both above ground and underground have their place, I think.
So I've got a lot of time for underground therapy. I think there's a very rich wealth of experience and knowledge that we have gathered over many thousands of years as to how to work with non-ordinary states of consciousness, and contemporary medicine would be very foolish to disregard this massive wealth of knowledge entirely. Underground therapy and working outside of sanctioned research can provide a lot of anecdotal data to power research and can push forward the field. And there's a great many very skilled therapists who work outside of sanctioned research. So I'm a big fan of that. With my other hat on, when it comes to licensing drugs and increasing accessibility of psychedelics, fucking flies, to the general public, the vast majority of my patients cannot and will not wish to break the law. And it is absolutely right that despite all the restrictions that go with scientific research, and Dave Nichols talked about this really well yesterday, all of the barriers and restrictions around funding and politics and working with the man, and all of this is very true, but it's all we have. And I wish to see my patients who cannot and will not go to underground therapy go into their GP surgery and have licensed, legal psychedelic therapy. And the only way to do that is through the man. So we have to be very careful not to polarize this into good and bad. There's good in both the sides, and there are necessary restrictions. I talk about this a little bit in my talk tomorrow when I'm talking about rebranding psychedelics and how we increase accessibility in the future. But what the people who hold the purse strings and the people who maintain the regulations and the authorities are extremely square and boring. And you should be able to walk into the offices of your ethics board and your MHRA board with long hair and a tie-dye t-shirt and say, hey man, it's my right to get high. How dare you dictate my brain chemistry? It's not fair. You should be able to do that, but you just can't. And we need to get over that as a psychedelic community, at least those of us who are interested in licensing these drugs. And so we have to become undercover hippies, and we have to cut our hair and wear ties and play their game. And then when we get these drugs licensed, we then slip in the transpersonal psychotherapy through the back door.
Thank you, Ben. I agree. We all need to cut our hair. Or just all wear a hat.
I don't know about that hair thing, though. I'm not sure.
Oh, well, I would have long hair if I had an option.
Just to follow up on that, I think, like one of the concerns I have is, once we get over this regulatory hurdle, that's in place by established legislation, there's another hurdle, which is the big money of modern medicine. And I think a lot of people are unaware of how established and quite how powerful that entity is, which is, it's going to be tough to explain to an insurance company why a person needs to have therapy for between 6 to 8 hours. They'll probably try to, say something like, therapy lasts a half an hour to an hour, and try to kind of fit it into the current treatment model. And I think moving forward, we really need to be careful to bring what we've learned from important underground research into the fold, and not to bring compromise because of convenience. And I think that's going to be a battle that's probably that we need to anticipate, and to not compromise the integrity of the therapy and the whole process that needs to go on. And it might take 6 to 8 hours, or it depends on the person, it depends on the drug, but there's real value in long sessions and things that really can't be pounded into a clean hour-long clinical format that is more conducive to billing purposes.
Yeah, it's a relevant question. How do you find the Medicare billing code for an 8-hour therapy session? How do you get that passed?
I think one way of looking at it is, with all mental health, which is chronically underfunded and undersupported all over the world, it's false economy to cut corners on doing it well. And so indeed, psychedelic therapy sounds expensive as an upfront cost, 16 weeks of 2 therapists, long, day-long sessions, maybe stay overnight in the clinic, expensive drugs. They needn't be expensive, but they are because of all the regulations. So up front, it would cost, I don't know, maybe upwards of £10,000 or £12,000, I would say, per person to put a patient through MDMA therapy. Probably more, actually. Probably more like 15, even maybe £20,000 in the NHS if you were to figure all the costs, which is a lot of money. And it's a lot cheaper to just give them a packet of Prozac and send them on their way. But it's false economy to cut these corners, because if you look at the long-standing chronic mental disorders. And the thing about mental health is most people with severe mental disorders have them for life. And I often say this in my talks, psychiatry is a bit of a depressing place to work sometimes. It feels like a palliative care field of medicine. We don't use the cure word. If you go to your psychiatrist in your 20s with a severe mental disorder due to child abuse, such as an addiction or PTSD, there's a pretty good chance you'll be going back to your psychiatrist in your 60s and 70s. Now, that's not good enough. It's poor. It's a terrible clinical outcome after 100 years of modern psychiatry. So it's extremely expensive to be mentally ill. You lose your job, you become homeless, you become addicted to substances. But the biggest cost of all in psychiatry is inpatient care. Standard hospital inpatient care in the UK is around about £5,000 to £6,000 a week per patient. On an intensive psychiatric care intensive unit would be more like £10,000 to £12,000 a week. And if you have multiple hospital admissions for 60 years of your life, you are extremely expensive. So yes, psychedelic therapies are an expensive upfront cost, but if they work to cure the patient, and this is a word I use with great trepidation, because it's been drilled into me that we don't cure people in psychiatry, just we care for them. If it can cure a person in the early stages of their illness and they do not have to keep coming back to their psychiatrist for the next 60 years, then it's money well spent.
We've got... Well said, Ben. Unfortunately, we are at the opposite end of the spectrum at the moment. Psychiatry, all it does at the moment is cut corners. I think that psychiatric care is abysmal. That's not a reflection on individuals, and I think we've got to separate institutionalised psychiatry we see in Australia, which is the revolving door type of psychiatry, mainly focusing on people with psychotic problems, ignoring everybody else, and the budgets for psychiatric treatment getting smaller and smaller in comparison to other specialties and areas. So we've got a long way to go. I agree that if this therapy works, it'll be fantastic, and ultimately will save a lot of money. But it seems that there's a sort of belief system amongst politicians, public servants, people who control the purse strings, that psychiatry is hopeless and there's nothing you can do about it. I don't know why we slipped into it. I suspect it's because the biomedical model is so strong. Give someone a pill and that'll solve the problem. When I was training, and this is 40 years ago, psychotherapy was much more respected than it is now, and people like Freud and Jung were at least listened to a certain extent. Now they're figures of derision, and it's a very sad state of affairs. So I think it's interesting that we talk about psychedelic-assisted psychotherapy. It's very important, as others have said, to say it's a type of psychotherapy. It's not the drug, it's the psychotherapy. And start from that. And if results can show, and I know Michael Mithoff's results are fantastic, can show that there's an improvement, that's where we can start from. So it may well be that psychedelic-based psychotherapy can begin this new process of getting psychotherapy back into mainstream treatment and less of an emphasis on big pharma and the sort of stuff they produce, sausage factory stuff, which isn't really producing any good results. As I said before, depression's the worst condition in the world. So we really have to look at it from an entirely new angle to get some sort of progress happening.
What would psychedelic therapy look like in an ideal world for you? How would the clinics be? How would it be administered? What would that system look like for you?
Well, I think this is a very, very difficult question to answer because the pace of change, you've got to look at the history. You could first ask, what would it look like now had we not had this 35-year hiatus? Had everything not ground to a halt in the end of the 1960s, and then we'd had a 30 years practical dark ages period, how would it look today? Where would we be in neuroscience, for example, if we were able to use psychedelics for the last 35, 40 years, like we have been in the last 5 or 10? So it's very hard to know where it's going to be 5 or 10 years from now. I think all we can pretty much say is if it carries on at this pace, it's going to become a lot more pervasive in all parts of not just mental health, but possibly physical health, society, law, politics. art, music, literature, chemistry, botany, architecture, and dance. Psychedelics have these tendrils that reach out and touch all aspects of academia and society and communal living. So what we mustn't do, which I was almost doing just then, is falling into this messianic sense of these are panaceas that are going to, if only we could all take LSD and be high, then we'd live in chemical utopia. That's clearly bollocks. And we have to hold on to a certain sense of humility that psychedelics nor any other agent or single issue is a panacea for humanity's awful situation it's in. Within medicine, as I said before, we're in the embryological stages of how we might use these drugs clinically. And who knows, I think we're going to have a vast broadening of different diagnoses and different ways of using them. And we have to just learn from the past and learn as we go along, and learn from the non-medical uses and the non-Western uses of these plants, and learn the humility of the experience, because that's what the human condition really needs to do. It needs to take the top off this arrogance that seems to be pushing us with our greed and consumerism. And it's not often doctors speak in that kind of language, but I think these are medical issues as well as societal issues. I'd like to see a broad use of psychedelics across medicine in different clinics, but also outside of medicine. They shouldn't be restricted to the clinical population. We should have centers where non-clinical populations can come and experience psychedelics in a safe setting for personal growth and development, for family development and social cohesion. So these are all aspirations rather than realities. I don't think any of us quite know, but I'm really looking forward to going along with the ride.
I don't want to bring a downer into it, but there are a lot of problems to confront. Set and setting are very important, and if we're going to use these drugs in a therapeutic way, and the psychotherapy is very important, there are all sorts of risks that the psychotherapy can go wrong. That you're going to get psychotherapists with ideas that aren't necessarily virtuous. I'm not saying that there are bad psychotherapists around, although there probably are. I'm saying that there are risks here with a drug that helps people to learn how to lead a meaningful life, that influences from the psychotherapist are very profound, and I think that is going to be a difficulty in the long term. If these drugs become generalised and are used in all sorts of psychiatric practices, that's going to be a difficult thing. It's going to have to be well monitored. And at this stage, of course, the research is at an incredibly high standard, and the people who are doing the research, a handful of people we know are good people, virtuous people. But that's something that I think will present as a problem later on. I'm not saying that we should stop doing the research now, because we need to do the research, but we have to be aware of the risks and problems that may evolve eventually.
Yes, I think that the future of psychedelics will be in some sense similar to psychotherapy, that it will be integrated in the current mental health services and clinics and hospitals. So it is one of the tools which can be used to treat the patient, because like you have patients and sometimes you use pharmacotherapy, sometimes you use them to psychotherapy. There will be another technique, another way how they can be treated. And also, as Ben said, so that there should be the clinics or centers for the healthy people, for which can use it for their personal growth or for creativity. And no, I forgot. Yeah, and I think that it's also super important to think also not just about mental health services, but also about social services, that there need to be developed this safety net for all the people which go to some psychedelic experience, and it is challenging or difficult, and they need some help, so they know where to go to talk about that, to receive help and support. And I also believe that it needs to be to make it effective and safe, that it needs to be much more complex, that it needs to go to the primary prevention, that we need to teach children to how to work with the consciousness, because now we teach them how to swim in the swimming pool, but we don't teach them how to swim in the ocean of consciousness. And I really believe that if we can develop those skills, for example, by meditation, by mindfulness, from the early childhood, that later we will be just much more able to work with the psychedelics, with non-ordinary states of consciousness in a much more effective and safe way. So yeah, education for children, for adults, and also then there need to be this training of the mental health professionals, and I hope that we very soon agree on that. One of the requirements to be able to administer psychedelics will be your own self-experience, which in 60s pretty soon they developed this system. You couldn't administer psychedelics if you didn't have undergone the 5 LSD sessions at least. So I think that is also a very important thing. Yeah.
Thank you for humoring my curiosity. I'm going to open it up to the floor, to the audience for questions.
I think it has to start with psychotherapy training. I think it has to start with the training of psychiatrists and psychologists. I think it's become, particularly in psychiatry, I can't really speak for psychology, it's become very biomedical, and the training of psychiatrists these days does not allow for what I said before, which is a psychotherapeutic approach, psychosocial approach to the treatment of people with psychological illnesses. They're illnesses in a sense, they're labelled as illnesses, but they're all sorts of problems of living, all sorts of distress situations which don't necessarily have a biochemical origin. And I think that we need to train people to understand that, more empathic, bedside manner stuff right from the word go. But look at all the great teachers of psychology and psychiatry over the last 100 years who unfortunately, whose wisdom is being ignored in the training program. And so I know psychiatrists who have come through training and all they know is tablets, and they haven't had a lot of contact with people who don't have psychotic illnesses. So I think it goes back to training people who understand the etiology of conditions, psychiatric conditions, psychological conditions, just the difficulties of living and how to deal with that, the importance of empathy, and the people I think who should be treating people with psychological distress are people who have gone through a period of self-reflection themselves. I'm not talking about 5 years of psychoanalysis. That put me off years ago. But I mean working out who they are, why they're there, and what they can do with their own skills and their own problems and their own challenges to help people with similar problems, I guess. And that's just on that point. I think that without that training, if we add the psychedelic component, we're multiplying the risks, because of the power of these drugs and how they can affect conscious states. So if we've got people who aren't all that self-aware of what they're doing with these drugs and what these drugs can do, and they don't have psychological understanding, there's all sorts of, I can see all sorts of problems. At the moment, as I said earlier, that's not happening. But if these drugs become generalised, we have to be very, very careful of the sort of people who are administering these drugs, because we're just going to increase the risks. Anyway, that's really a summary of what I believe.
I think coming off of what Nigel was saying, I think that it actually is going on, especially with the recent explosion in interest in ketamine from various practitioners, and giving low to moderate doses of ketamine and inducing dissociative or psychedelic experiences in participants, and then afterwards not really having a lot of understanding of what those experiences mean, and not a lot of desire from clinicians to talk about the altered states that people were experiencing. And so I think, just within the last few years, we've had a psychedelic being introduced sort of quite outside of the lineage of psychedelic therapy, and it's been introduced into psychiatric practice. And I think so, we haven't seen it yet with classical psychedelics because they're not widespread, but I think that we are seeing it with ketamine specifically. MAPS approach is that they got approval from the FDA to dose the therapists, to give MDMA to the therapists themselves, which of course has been done in unsanctioned underground treatment for since its inception. But I think is one critical component of MDMA therapy and psychedelic therapy in general is understanding what these drugs are, and that they're not just standard antidepressant pharmaceuticals that you can kind of just like sit back and see what happens to the patients. That there's an active experience that the patients undergo, and that the patients either need to talk about those experiences or need some guidance from others through group sessions on what those experiences mean. But I think just from the clinician standpoint, I think it's critical that these powerful substances and their effects are understood on that very real personal level by the people administering them. I think that's a critical component of the entire thing.
Thank you. Got a question in that corner?
Could I just say something quickly to the questioner, very briefly? I would like to sincerely apologise on behalf of the profession of psychiatry for your ill treatment. You come to the profession in a state of vulnerable distress, and you deserve to be treated with great respect and care. And it is so disheartening when I hear that people have had poor experiences within the profession. And we must strive as clinicians to be deeply compassionate and caring. I love my patients. I care for them deeply, personally. And I work for them. The first thing I say to a patient is, you are the boss, and I work for you. What would you like me to do? And I will work fastidiously, and I will not give up, because you deserve all the care you can have. And I think if clinicians can take that standpoint, come off their ivory towers, reduce their level of hierarchy and professionalism, and meet people and connect, we can't go wrong.
I don't know, you ask questions that I don't think we necessarily have answers as yet.
Does it start with the training? I think even within medicine, there's been people who experience substance use disorders are one of the most stigmatized populations in the world. And there's been increasing training among general practitioners or medical students to increase their empathy toward this particular group of patients. And so in order to change, you can't change, I don't think you can change it from the top down. It has to start from the way training is being provided and changing it up.
I think one of the problems starts, it's a multifaceted problem. And one of the components, I think, is risk aversion. We are living increasingly in a world where we are unable to sit with risk, we're unable to tolerate risk, particularly in the public mental health system, where you see the people who are at the most pointy end of the wedge, who are most acutely unwell. The tolerance for risk is very, very small, mainly because of the potential for something, if something were to go wrong, so to speak, and the potential for litigation is extremely high. And that does drive clinicians towards being, again, more risk averse, towards jumping towards diagnoses quicker, because once you have a label, then you can medicate, then you can be supported by your indemnity organization. that's just some of the factors outside of clinical training and outside of clinical medicine that affect the practice of psychiatry, fortunately or unfortunately. There's also a big difference between public psychiatry and private psychiatry. In private psychiatry, I mean, Nigel and Ben may be better suited to comment on this, but there's a bit more license for autonomy than in the public mental health system, where you tend to be rather embroiled in sort of the factors that I've just spoken of. And in private psychiatry, perhaps there's there's a greater chance of achieving what you're asking for, Dean, because it's very much dependent on the individual.
Yeah, I agree with both of those two replies. It comes down to training and it comes down to resources. And also, somewhat in defense of psychiatry, I think that it's quite popular, especially amongst this kind of crowd, to just keep talking about psychiatrists as proponents of the medical model. Now, all the psychiatrists I know are really not primary proponents of the medical model. It's arguable, in fact, that psychiatry is one of the more holistic fields in all of medicine. I've found a far more restrictive medical model in other branches of medicine, where the patient is just a broken bone in a bed or a bile duct to be cannulated. Psychiatrists, and throughout training, generally in my experience, are very in touch with the psychological and social issues of our patients. We have to be, because we know that there's no point in just giving a patient drugs if you're not going to also help them with their children and their relationships and their job and where they live and their benefits and their aspirations. We know that those are active parts of the treatment. So any half-decent psychiatrist would be a good holistic doctor. And I have no doubt people have experiences of poor psychiatrists. But in my experience, they are not as common as we think. Most of the psychiatrists I know are very broad-minded, very holistic, very non-medical approach. But then I totally agree with the other point. And it's certainly in the UK, it's about resources and availability. And when the resources are cut, as they have been cut year on year for the last 25 years, the UK government is systematically winding down the National Health Service. They're very open about this. And when you cut and cut and cut, the bar goes up for access to the service. So people will say, all you psychiatrists want to do is lock people up. My God, I wish I could get more people into hospital. I cannot get a person into hospital because it's impossible to find a bed. So I don't think that people are over-treated with this zealous psychiatric model. I think people are under-treated because we do not have the resources. And when you cut the resources, you only do the risk-averse stuff. So in order to get a psychiatric bed in hospital these days in the UK, you literally have to be wielding an axe, ready to kill someone or yourself, or in a highly psychotic state. And this goes very much at odds with the textbook training. When I was training 25 years ago, we talked about bringing someone into hospital for 6 weeks to review their diagnosis and wean them off their medications and see what emerges. That is absolute fiction. You're not going to get that nowadays. You're lucky if you get 48 hours in hospital and then booted out again to a complete absence of community care services. So sometimes I think we need a stronger medical model because we've almost got no model at all at the moment.
It's different here. You can be wielding an axe and you can kill someone, you still don't get a bed in hospital, you have to stay in prison. There was a recent court case, the judge said he couldn't believe it. There's a queue to get into forensic psychiatric services here. You've got to wait in prison until they've got a bed for you. But on a lighter note, just a couple of points. I don't want to paint a picture of psychiatry being all horrible and terrible. There's some really terrific psychiatrists out there working in private practice and public practice who really are what I'd call phenomenologists, who are really into being with the patient at the moment to find out what their perception of life is and what they're experiencing and how to share meaning and develop some sort of strategy to help people. And so there is a lot of good psychiatry. I think what we're talking about to a certain extent is institutionalised psychiatry and academic psychiatry, the tendency to diagnose and so forth and use the biomedical model. When I was a young psychiatrist, a professor of mine, Sid Block, who's still alive, said that psychiatry is like a three-legged stool. One leg is the science of psychiatry, one leg is the art of psychiatry, and one leg is the ethics of psychiatry. And I really believe that's a nice way of looking at it. The art of psychiatry, which I really try and practice to the best of my ability, is a subtle thing, and it can go wrong and it can go well. We need to... I remember when I learnt psychiatry, you can learn the drugs in about 10 minutes. There's 20, 30 drugs. You can learn them, you know the side effects, you know what they do. That's the easy bit. The hard bit is to get to know your patient and how to effectively help the patient. It's the art of psychiatry with the ethics. Art's no good without the ethics. That's the balance. And it's not an easy thing to do, and it's not an easy thing to teach. But there are a lot of good people out there, and there's a lot of good psychiatry being practiced. It's just that the way it's viewed by government and institutions and bureaucracy is awful, and they don't get it, they don't understand it. Partly because how do you statistically measure an art? You can't. And that's the great difficulty. And how do you prove that you've helped someone when it is a discussion and a conversation and a period of knowing someone, a relationship? Very difficult. And I don't think... one of the reasons I love psychiatry is because it's so controversial. It's racked with controversy and schisms and all that sort of stuff. Because we're talking about human consciousness and the human condition. Never going to be solved. It's always a mystery. It's a mystery to be lived. And that's why I love psychiatry.